So our second panel of the day is on equity and inclusion in healthcare. And for those of us who were here in the morning, we can see that some of the concerns that we'll be addressing now this afternoon certainly came up and are a part of all of the concerns that we will be addressing throughout the day. It's a crucial, challenging aspect of healthcare delivery and healthcare reception, entrance into the medical profession, care bestowed by the medical profession, given by the medical profession, research, how research is sufficiently accounting for a range of demographics and people who identify differently. And this happens to be a concern very important to me, and I know a couple of my students are here and will attest to that. I'm really grateful to everyone who's going to be speaking on this panel, and I'm going to start to introduce the first of them now. We're delighted to have with us Dr. Marcia Anderson. She is Cree Anishinaabe and grew up in the north end of Winnipeg with roots in Peguis First Nation and Norway House Cree Nation in Manitoba. She practices internal medicine and serves as the Vice Dean, Indigenous Health, Social Justice, and Anti-Racism in the Rady Faculty of Health Sciences, University of Manitoba. Dr. Anderson has won multiple awards, including the 2022 Doctors Manitoba Physician of the Year Award, Community Development Award from the Mahatma Gandhi Centre of Canada, and the Lieutenant Governor's Award for Excellence in Public Administration. So thank you very much, Marcia, for being here.
Great. Thank you. I wasn't expecting applause before I even started. Amatakape potato to anamakiae, Nandawe Benusik Ndishnikas, Peguis and Norway House Ndunji, Chante Washte Nape Chizape. So I've just introduced myself to you by my Dakota and Anishinaabe names as well, and told you where my land is and what my communities are, because that is actually the core from which my ethical principles are drawn. And before there is a social contract between people, there are responsibilities in a covenant relationship with the land that you occupy, have settled, live on, or are your homelands. That covenant relationship with the land is meant to be continual and reciprocal for all who derive life from it and embed respect with all our relations on it. The WHO statement on the right to the highest attainable standard of health has as a core principle that in any health planning decision making, we are meant to center the needs of those who are furthest behind first. This rights-based principle, as well as the principles of social justice and anti-racism, were principles that were core to who I am before I was a doctor and inform every aspect of the work that I do. The Truth and Reconciliation Commission of Canada, in its calls to action, number 18 specifically, calls on us to understand the current state of Indigenous health, including the wide and growing Indigenous health gaps as a result of previous and current government policy. This is not limited to health policy, but to all public policy that impacts our lives and the full expression of our rights. One of the gifts or lessons of COVID, should we choose to accept and finally learn it, was the real-time visibility of the impacts of public and health policy decision-making on health gaps and on the healthcare resources available to everyone. In Manitoba, as a public health doctor, a lot of the work that I did was focused on First Nation specific responses, as well as developing the infrastructure to be able to disaggregate all of our COVID data by race, ethnicity, and Indigenous identity. This data was tightly governed through teams that I led and a BIPOC expert advisory committee of people mostly outside the healthcare system who had expertise that we don't usually find or consider relevant in our healthcare system, including critical race theory, human rights, critical gender studies, and community organizing, amongst a few. We spent multiple of our initial meetings talking about how do we maximize the potential benefits and minimize the potential harms of having data that is disaggregated by race, ethnicity, and Indigenous identity. Because our histories in the development of the Canadian state, being founded on the pillars of anti-Black and anti-Indigenous racism, mean that we can't trust the people who presume to own our data to tell us about us or make decisions in our best interests. And so the tightly governed work that we did was to be in control of that narrative. Now, what our data showed, and I'll talk about it a little bit, was that there were gaps in COVID-19 exactly where we knew there were going to be gaps in COVID-19 experiences. Because racism and colonization have been the structural drivers of how policy decisions get made on our homelands since the beginning of the Canadian state. Those are the reasons we have the education gaps that drive health gaps. Those are the drivers of the income gaps that create health gaps. Those are the drivers of the unequal access to employment that massively impacted who got COVID-19, who was more likely to be in a part-time service-based role without paid sick time or benefits, who were in occupations that were always essential and in person without adequate PPE, and who, on the flip side of the colonial racial coin, could work safely from their homes remotely, virtually, in their higher income jobs where they could isolate in private bedrooms and private bathrooms. Which of course brings me to the housing gaps. You know, by the time the Delta wave hit, the secondary attack rate, the rate of people living in homes where one person got infected was 100% in Manitoba First Nation communities. If one person got COVID-19 in the home, everybody got COVID-19 in the home. And I would ask you to keep in mind that under the Indian Act, we cannot own our own homes on reserve. This is a problem the Canadian state has enshrined in legislation to other people's benefits. So because these have been part of the reality in the Canadian state since the founding of the Canadian state, we knew that this would create gaps. We've seen this with Spanish flu. We see it every year with influenza. We see it with tuberculosis. We saw it in 2009 with H1N1. And this time we did some things right. The National Microbiology Lab had access to rapid testing devices, for example, GeneXpert, Abbott ID technologies. They prioritized deployment of those machines to remote First Nations and Inuit communities. So when my team was deploying rapid response teams in communities with outbreaks, we could have testing done the same day instead of the 5 to 7 day turnaround time flying, transporting the swabs to the provincial overwhelmed lab would have taken to us. That made real differences when we could pre-position people in alternative isolation accommodations who were at high risk of severe illness closer to tertiary care before they needed it. But we did not do everything right? And I'm going to use the example of vaccine policy decision-making to highlight this. So what our data showed, and we put it in the public eye on a daily basis, was that not only were First Nations people at higher risk of COVID-19, they were also at higher risk of severe outcomes due to COVID-19 and at significantly younger ages. The median age for hospitalization for First Nations people was a full 15 years younger than in the general population. We leveraged that data to ensure that First Nations people had the earliest access in the community-based rollout. And then further, to get it to the point where when we had a little bit more vaccine available, we immediately went 18 and up in First Nation communities. That saved lives. Where we didn't see the same equitable, data-driven decision-making was for off-reserve First Nations people. Now, Some decision makers and planners have in their mind that remoteness and geographic access is the key determinant of access to healthcare. It's not true. And so what our data consistently showed is that urban First Nations people had at least the same risk as on-reserve First Nations people. But because NACI initially only included people in remote communities and how they advised governments to prioritize decision-making, it delayed access for off-reserve First Nations people who continue to experience severe outcomes at younger ages. The other thing that we knew was that amongst diverse BIPOC communities, including African, Black, South Asian, Filipino, and Latinx communities, the exact same pattern was being seen of higher rates of severe illness at younger ages, at least a 15-year age gap. But like everywhere else in this country, the community-based, age-based rollout was colorblind, which meant that BIPOC folks had to wait on average 3 weeks longer for the same protection at the same risk level. The impact of that meant that during the worst wave that we had, people who were at the most risk of severe illness were underprotected. You might recall that is when we ran out of ICU resources in Manitoba, and when we were flying people out of our province to receive the health care that they needed. You might intuit that because of how decision-making goes around who is going to have the best chance of being transported, which was incredibly high risk for COVID-19, that more young Black and Indigenous, other racially marginalized peoples were flown out of province for that health care. And you might even recall that we lost a young First Nations woman on the tarmac during one of those transportations. This also caused significant delays in other necessary forms of health care, because any procedure that had a high likelihood of requiring ICU care was delayed. And so in my other job as an internist who does mostly community cardiology, I often thought of my one older white male patient who waited at least an extra year, probably 18 months, for his mitral valve replacement, barely able to walk, because it's very difficult to manage symptoms when the only real treatment is surgical at that point. This could have been different. And I think it is critical that we always remember that this could be different. We have created these conditions through repeated policy choices. So when we think about the affordability and the sustainability of a publicly funded, publicly delivered healthcare system, we have to also think about costs and the costs of not doing things differently, and how things could be different if we actually centered the needs of those furthest behind first. My MPH back in 2006, 2007 was from Hopkins, and I studied, my advisor there was Dr. Thomas Laviste, who's a leading scholar in race-based health disparities in the United States. In 2011, he published a paper where he looked at both the direct and indirect costs of racial, ethnic, and Indigenous health and healthcare gaps in the United States from the period 2003 to 2006. If we eliminated health gaps, the paper found, this is American, it would save $230 billion in direct healthcare costs and indirect costs of more than $1 trillion. Now, when I was double checking the numbers of this study prior to coming here today, I noted that, or found that he published a new paper this year with an updated analysis. And in 2018 alone, the economic burden of racial health gaps in the United States was between $420 to $450 billion. We don't need, to an earlier point, we don't need that money poured into healthcare, but we do need to pour that money into better, equity-focused, ethical, public policy decision-making if we want to improve health outcomes and have a sustainable healthcare system. Miigwech and mtakoyasin.
Thank you very much. Much to talk about. Next, we have Richard Budgell. He was appointed assistant professor in the Department of Family Medicine in 2020 here at McGill. He is a Labrador Inuk and lectures, writes, and does research on Inuit health. Prior to joining family medicine, he was a federal government public servant in First Nations and Inuit health and other Indigenous fields for more than 30 years. He was awarded the Queen Elizabeth II Golden Jubilee Medal in 2002 for exemplary public service in his role in the creation of the Aboriginal Head Start program, an early childhood development program for First Nations, Inuit, and Métis children and families. He has a Master of Arts degree in Canadian Studies, Aboriginal concentration, from Carleton University, and began doctoral studies in history at McGill in 2021. He's involved in a variety of research projects, including Inuit cultural safety in healthcare and the Inuit community in southern Quebec. Thank you very much, Richard.
Thank you. Nakoik, thank you. Unusakut, good afternoon. So I made a special request, and the organizing committee was happy to accommodate me. I said, we can't talk about Inuit without showing maps, because we are our geography. So I'm going to show you a couple little maps and explain them to you. Part of what I like doing, I enjoy doing, I'm arguably paid to do, is to smash paradigms and destroy long-held notions about who Inuit might be. This is a map of the transnational, through 4 countries, Inuit homeland called Inuit Nunat. Those 4 countries, nation states that are included here, include Greenland, Kalaallit, Nunat, still part of the Denmark nation state, Canada, Alaska, and barely visible there is a tiny piece of Russia, Chukotka, where Inuit-related people live. That global population of a people, and this is how Inuit want to be described. We want to be described as a people. That global population is 180,000 people. So that makes us a significant people in terms of those demographics. I would contrast this to the Quebec portrayal of Inuit. I am not particularly picking on Quebec, but this is where I live. So this is where Inuit, like me, are subject to this portrayal of us. The portrayal of us is of course, people who live in an unimaginably distant kind of region, the Nunavik region in Quebec. In fact, it is not that unimaginably distant. It is the top third of the landmass of this province. You can get on a plane in Montreal and be in Kuujjuaq, the biggest community in Nunavik, in 2.5 hours. And for Inuit, that is not seen as a major distance. That's a distance easily transversed. The population in Quebec is, through 14 communities, about 13,000. Now about 2,000 of that population lives in southern Quebec. So we are, in fact, an increasingly urbanizing community. We are described in this jurisdiction as the Inuit nation living in these isolated communities. But as I have told you, our sense of ourselves is as a people. We don't use that nation terminology. It is, I think, somewhat convenient for the government of Quebec to slot us into a particular kind of box, along with First Nations, who are slotted into boxes relating to language, relating to geography. But I think it's important to say, and this is, this goes way, way back, hundreds of years back into colonial constructs and colonial history. We're not necessarily as described by the people who have colonized us, people and entities that have colonized us. And we have a different kind of vision about ourselves. So this Canadian landmass portrait here shows you these dots, 52 communities going across Inuit Nunangat, which is the name of the Canadian space. That represents a population of about 70,000. Out of that 70,000, now about more than 20% and approaching a quarter of that population lives in southern Canada. So the statement that I made in relation to Montreal is true across Canada, that the Inuit population is increasingly southern. The growth rate of that southern population is higher than the growth rate of the Inuit Nunangat northern population. So that kind of demographic shift, I think, is only going to continue. So that tells us something about the direction of services, that services should be increasingly available to people, to Inuit who live in southern Canada, and we will have, as has been the case for First Nations people for some generations now, ultimately a multi-generational southern population of people who live at some distance from their places of origin. Very important for me to add, and I can speak absolutely personally about this, that geographical distance from our places of origin doesn't mean emotional distance or intellectual distance from our places of origin. I think we typically feel very close to our places of origin, and that's absolutely the case for me. Have roots in a couple of small communities in Labrador. I am very close and in very, very close communication with my family from there, and that is typical, I think, and common, and I think something that we have in common with First Nations people also, that our living in one place does not transform you and detach or separate you from your place of origin, and I expect that will continue to be the case. What we are what we are stuck in, like all Canadians, is a Western medical paradigm. We were talking earlier, and friends of mine say, can you speak a paragraph without using the word paradigm? And I try, but it just sometimes fits. We are in a Western medical paradigm. So that Western medical paradigm, this slide gives you a bit of a description across Inuit Nunangat of the state of hospitals. Hospitals are, of course, a central symbol of Western healthcare. There are hospitals within Inuit Nunangat. In fact, this hospital that's pictured here is the Qikiqtani Hospital in Iqaluit that I was at about a month ago. From all appearances, it's a very good, perhaps even superior hospital. They have 3 surgeons working in that hospital. That demonstrates a fairly high level of that kind of care in a facility of that kind and size. So in fact, I'm not a physician, but I found it impressive and in fact somewhat comforting to see. However, part of that structure, part of the organization of healthcare throughout Inuit Nunangat is this another map. This shows distances of medical transportation experienced by ordinary, in fact, ultimately, probably nearly every Inuk that lives in Inuit Nunangat that is requiring particular forms of medical care. So the distances are, even for a people that is accustomed to crossing large distances. Some of these distances are pretty incredible. The Grise Fjord, and this is a normal trajectory, and a not uncommon trajectory, Grise Fjord to Ottawa for healthcare, 3,461 kilometers. That I'm sure must be some kind of record within Canadian healthcare and perhaps even internationally, that anyone would go that kind of distance to receive healthcare. I've talked about, written about, will continue to talk and write about medical transportation. I don't want to be identified as a kind of one-issue person, but it's incredibly significant in the nature of healthcare for all Inuit, who live in Inuit Nunangat. I believe it demonstrates a form of systemic racism, because I believe it demonstrates that alternatives, even where they can be considered, alternatives are not considered. And the many hundreds of millions of dollars spent on medical transportation annually across Inuit Nunangat means that those hundreds of millions of dollars are not being spent on anything else. They are not being spent on enhancing the capacity of local healthcare throughout this very large landmass. And I think that demonstrates represents a form of systemic discrimination for Inuit. Another factor of the nature of healthcare throughout Inuit Nunangat is the very severe underrepresentation of Inuit as providers, as professionals within that healthcare system. There are not, at the moment, and I think this is an information gap, there are not good demographics about the numbers of Inuit professionals working in our own healthcare system. Anecdotally, numbers, if you start to look at, for instance, physicians, and the numbers are so small, and our world is, in fact, fairly small in a certain kind of way, that I can say I know of 4 Inuit physicians. 2 of them are cousins of mine. We live in that kind of world where we have this kind of relatedness amongst ourselves, but the total numbers are probably not radically higher than the number that I just gave you. When it comes to other kinds of professionals like nurses, those numbers might be in the dozens, but small dozens. And I think for me to continue to make this kind of argument, it would be really useful for me to actually have quantitative kind of data here, and that's something I might work to fix. But that underrepresentation within the system means that you do not have Inuit intelligence. And the word for Inuit intelligence in Inuktitut, Inuit ways of seeing the world, is Inuit hauhimaturangit. So it's a word that implies the Inuit ways of seeing the world and Inuit thought and Inuit tradition. You do not have many Halunat non-Inuit who are proficient in Inuit ways of seeing the world. Those people exist. There are people like that who exist, absolutely. People who have been wonderful companions and colleagues and friends to Inuit who have very good understandings of Inuit, but Inuit intelligence is vested in Inuit. If you do not have that kind of intelligence within a system, that means that you are not getting decisions made, you're not getting recommendations made that are informed by Inuit thought. And that's an issue, I think. That is a significant issue. That means that the form of healthcare that Inuit experience is not a form of our design, not a form of our creation, and that's a problem. I'm going to just finish with a couple of, I'll read you a couple of pieces of text from the United Nations Declaration on the Rights of Indigenous Peoples. That's a massive document, a massive global document. Sometimes it's hard to take that kind of massive global document and see its application to a person who has to come to Montreal to have their baby from somewhere in Nunavik. But I would argue we should work to see that kind of application and make those kinds of connections because it's relevant. The United Nations Declaration on the Rights of Indigenous Peoples, UNDRIP as it's frequently called, makes statements about rights. And rights have a connection to ethics. And the theme of this conference today is ethics, so I just wanted to make that semantic, intellectual kind of connection between rights and ethics. Article 21 of UNDRIP, Indigenous peoples have the right without discrimination to the improvement of their economic and social conditions, including inter alia in the areas of education, employment, vocational training and retraining, housing, sanitation, health, and social security. So makes a clear statement in relation to health. Article 23, Indigenous peoples have the right to determine and develop priorities and strategies for exercising the right to development. In particular, Indigenous peoples have the right to be actively involved in developing and determining health, housing, and other economic and social programs affecting them, and as far as possible to administer such programs through their own institutions. It would be, I think, a bit of a stretch to say that these institutions that exist throughout Inuit Nunangat are of Inuit creation and are our own. We have roles, we have involvement in these institutions. Where I'm from in Labrador, that goes back more than 100 years. But are they ours? Do they feel like they're ours? I doubt it, frankly, that any Inuk would say that these are currently our institutions. And then finally, Article 24, Indigenous peoples have the right to their traditional medicines and to maintain their health practices, including the conservation of their vital medicinal plants, animals, and minerals. Indigenous individuals also have the right to access without any discrimination to all social and health services. And that article goes partly to the point that I am making about the importance of Inuit, Hauhimaturangit Inuit intelligence within the system. So I urge you to, in your various roles, to begin to look at this question from a variety of perspectives, including including inclusion, and whether the people who are patients in the system also see themselves as the managers, as the professionals within the healthcare system. Thank you very much. Nakomek.
Thank you very much, Richard. Next, we're hearing from Sita Ramdas, who is the Associate Director of the Office of Social Accountability and Community Engagement of the Faculty of Medicine and Health Sciences at McGill. She's known for her patient and community advocacy for socioculturally safe and equitable healthcare, inclusion, and respect for diverse, vulnerable, and marginalized populations. She has over 30 years' experience in healthcare communications, community, and media relations, and has been recognized for her role as co-lead researcher and author of a report highlighting systemic racism and discrimination in Quebec. Thank you very much for being here. And I should note that Sita stepped in quite late when Rita Sharon was called away and unable to be here, but I'll say a little bit about Rita's contribution at the end of our panel today. Thank you again, Sita, for stepping in.
Thanks, and thanks for that disclaimer. So if I'm doing a lot of ers and ums, you now know why. It's really wonderful to be here with these wonderful panelists, and I'm very privileged to be able to talk to you today a little bit about the study that I did, because part of talking about that study was once, you do a report that highlights systemic, the official word we used on the report was systemic discrimination in a local Quebec hospital, because the word systemic racism just touched a few nerves, so we had to tone it down. But you can download it from the website. Just Google CAIDE report on systemic racism. The CAIDE stands for the work that an entire committee, a multidisciplinary committee made up of community members, patients, caregivers, and an array of healthcare professionals and people that they recommended to be part of the committee. It stands for the Committee for Action for Inclusion, Diversity, and Equity. And the most important letter in that acronym, CAIDE, CAID, was the A, because as a member of the board of directors of the very institution that this was done on, and who asked me, they asked me to do this report, which I think is very brave of them. They wanted to do a survey of their healthcare facilities and to see where did they land in the context of equity, diversity, inclusion, in both the context of the communities, the very socioculturally diverse communities they serve, but also in terms of their workforce. And that was courageous. It's a courageous undertaking. And it's only meaningful when an organization undertakes something like this if they're actually going to implement the findings to make significant change. There's the other option that things could be done for the optics of doing it, right? So let's hope it's for the former, not the latter, she said cynically. So it's no surprise to you that Quebec is a very socioculturally diverse society. It's also a culturally hybridized society. We have people from different cultural backgrounds mingling and getting to know each other intimately, and having progeny who are now carrying multiple sociocultural identities. And actually, a report that I read recently said that Quebec is actually the province with the most people that are minimally trilingual. So we're not just bilingual, we're trilingual. People have English, French, and some other language, which is really great, because that is helpful to have a healthcare workforce where we have people on the workforce that might have a different language that corresponds to some of the very diverse cultures that we serve, and the diversity of languages within those cultures. And that's a point about sociocultural representation. I think we all kind of are aware that sociocultural representation by your healthcare providers, your healthcare workforce, actually many studies show leads to better outcomes for members of our society who are socioculturally diverse. So if you are an Indigenous patient and you happen to have on your healthcare team someone who's Indigenous, there's a cultural understanding, a language understanding, customs, food, diet, belief understanding that they have that puts the patient at ease right away and actually leads to better outcomes. If you're from the Black community, which is a very diverse community within itself, and you have someone from your community on your healthcare team, the interactions are easier. Culturally, there's an understanding that happens. And I don't just like to talk about these things. If I could just give you an example of that. So, you have a patient, and I'm using real patient cases because these were brought to my attention in my context in healthcare communications. I often receive the complaints from people who do not want to go to the ombudsman's office because they saw the ombudsman's office of the hospital as an extension of the hospital bureaucracy, and they were just historically afraid to go to any bureaucratic office. So they would come to the public relations office where I would be quietly sitting, and they would ask, or tell me about some of the encounters that they had. And that's how I got to be familiar with patient cases and ended up being able to be part of some of the grand rounds as a non-clinical attendee initially. But it helped to actually clarify things on a sociocultural communication level for the healthcare team. And so a patient who is Black, West Indian, for example, in his intake, very articulate gentleman, very educated, is asked, do you have any allergies? Standard question, right, in medical intake. Any allergies? And basically says, yes, I'm allergic to pears. And so pears is fine. It's noted in his thing. It's got a little sticker, yellow sticker on the hard copy charts. Back then, this is pre-OASIS, which is currently down now. But he later on, he gets a meal, which is basically chicken, rice, and a salad that's drizzled with avocado dressing. And he has a terrible allergic reaction. And why does that happen? Anybody can guess? And guess what? It didn't actually have the fruit pear in it. Anybody with a West Indian background think they know where I'm going with this? Nikita, you're nodding. Where am I going with this?
He was referring to avocado pears, but they thought it was the Canadian.
Correct. So, this is a gentleman that's actually from the Caribbean. I'm trying not to give too many details to make him as de-identified as possible. But on his particular island, which is my island, does the same thing. I'm from the same neck of the woods. Avocados are called pears. And this is a word that we use. So in his context, he was saying, I'm allergic to avocados. But the interpretation is that he's talking about the fruit that we know, the Canadian version of a pear. So it's a simple example of how that sort of socioculturally foggy area, gray area that you step into can actually cause harm to a patient. And it's not intentional harm, but it does happen, and more than once. So throughout my career in healthcare communications, one of the things I had to do was really speak to the communities and get out and promote all the successes of my hospital to very diverse communities and bring that information. This predates the internet, and you're probably wondering, all the younger people, how did you get information out when you didn't have internet? Well, we had to use a hospital newspaper. You remember Ensemble? We had to use different kinds of departmental, memos that are phoned in and voice recorded to people's homes, and town halls where people had to look in the newspaper and actually come in to get information in the hospital. But then websites started to come in, and I had to start now looking at how do I get information on the website. So easiest way for me that made sense was talk to the community and find out, what do you want on the website? What do patients need on the website? But when you're talking to different communities, they identify different needs. Then you recognize you have to deal with healthcare literacy. The community is at different literacy levels. And the ideal in the world of healthcare communications, the ideal literacy level is grade 7. That's actually gone down to grade 6 now because we have so many newcomers in Canada. So We've made it a little easier to communicate with them. So web content standards, you're looking at grade 6, maximum grade 7. But then there was the question of digital literacy, right? How many people have access to a computer or a smartphone or a printer? And digital literacy is another barrier. So if you don't have those computer skills, or you don't have the adequate devices, or in some rural areas you don't even have appropriate internet service, you are now experiencing multiple levels of barriers to accessing healthcare and healthcare-related information. So you're probably wondering, why is she telling me all this? Well, I'm telling you all this because over decades of working in the field in healthcare and trying to promote it, I also had to promote research, and I also had to recruit people from the different communities into research. People were so interested in, like, oh yeah, we want to study the indigenous community, we want to study the black community, we want to study the community of people who have different abilities. And you had to find ways of reaching these people, but I knew that I had to do it personally in a way that was not going to be social and medical exploitation. I had been well trained coming out of McGill with my clinical psych degree in research and experimental design, and I wanted to ensure that I followed all the research ethics policies at the time. The Tri-Council ethics policy had come into play. It wasn't yet addressing the issues of EDI, but there still was a lot of issues around, safety for different marginalized groups. What's interesting is when I engaged with the communities, I realized that I went to them, and the researchers wanted to bring the people into, like, the lab or into sterile environments, like conference rooms and so on, and talk to them. But when I was in the community, so I worked with the Cree Health Board, for example, there are physical structures and interactions inside of those communities that give you more information than just talking to a person. Living conditions, as I said, just the fact that they can't get proper internet service, these are all things that actually help inform you. So I started to talk to my researchers and say, if you really want to learn about these different communities, and I'm not just talking on an ethno-cultural level, I'm also talking about serving communities who are definitely underserved, such as formerly incarcerated persons, persons who have substance disorders, dependency disorders, persons who are homeless, et cetera, et cetera. The LGBTQ spectra and abrosexual communities. These are all very diverse communities that we know very little of, and we do not necessarily measure their experiences and get an understanding of what their needs are. And so I said, you've got to go out there to these people in their communities and see what's happening and talk to them there. Because when you go into, if you're familiar with the Côte-de-Neige district, anybody familiar with the Côte-de-Neige district of Montreal? You go into the Côte-de-Neige district and you see an apartment building on Barclay Street, full of all kinds of different ethnic groups. That apartment building is not an apartment building. It is a village. And in that village, you have the local religious leader in that building. You may have the local babysitter for everybody's kids in that building. You have their local medicine person practicing their traditional medicines. There is a plethora of amazing sociocultural information inside of these communities, and you only get to learn it if you go there. So, all this to say, while I was on the board, and they wanted to do this portrait of equity, diversity, inclusion in the institution, they wanted to look at the sociocultural diversity, the representation, and get a better understanding of where they were at. I realized I had to live by my own words. So I made sure, with my colleague, Dr. Anita Brown-Johnson, who did this study with me, that we realized we're going to have to use different ways of getting people's input about their experiences within the healthcare organization. And most people would go, okay, so you probably did a survey. Yes, in part. Surveys are easier to do, certainly to distribute it among the healthcare staff wasn't going to be a big problem, but I had to consider the digital literacy and digital poverty challenges that the community may have. So we had to find different ways. There's also the issue of privacy and protection of information. So we had to make sure that we did it in a way that was safe and anonymized for people to participate. And we also had to be, in terms of sociocultural safety, look at how people wanted to give us their feedback. Now, traditionally, people from the indigenous communities, people from the Black communities and other marginalized groups do not trust the hospital bureaucracy. There's generations of historical kind of marginalization they've experienced. So the ways that they said that they wanted to, because I asked them, I went to them, they said, we want to talk to you because we trust you. And then I said, but it can't just be me. You need to have somebody else there to take notes. I can't do all that by myself. So they had confidence in me, and I brought in someone else. We had to have focus groups one-on-one with some people who said, what I have to tell you is so delicate that I don't want to have anybody else around. Some people felt better collectively as a group telling us things, and other people were happy to just do the survey and trusted us enough to send in the surveys, which we de-identified. The other big part of this, as we were moving forward, we also made sure that the communities themselves helped to shape the questions in ways that the questions were socioculturally safe for them to answer, were socioculturally inclusive of them. So it took about a year to just polish off the questions, and even once we got it polished, we still floated it out to them, had them re-vet it, had them be comfortable enough with the way we had to compromise on certain things, because we can't make the survey like 2 hours long, like me going on right now. But we did actually end up with a survey that we disseminated, and we got great feedback. What we ended up learning was very interesting. So I'm sure some things will surprise you and some things may not, but we did learn that there was a great deal of racial discrimination, gender discrimination. We learned about all the different isms and phobias throughout the institution: Islamophobia, anti-Semitism, ageism, ableism, xenophobia. All these different isms and phobias were brought forth. And what was interesting, and I'm not sure how surprising it would be for you, is to learn that many of these isms, phobias, marginalizing statements being made, racially harmful, misogynistic statements being made, where in the institution would you guess that these things were really coming from?
Yeah.
Yeah, I heard two really nice whispers. The top and everywhere. In fact, there was a little bit, it was like equitably distributed at all the different layers of hierarchy in the institution. But the worst, most damaging things came at the top. And what was even worse when it comes from the top is that the top was also exempted from any sanctions that the very institution's policies had against such behavior. So punitive measures can be implemented at the bottom.
Just to let you know, we're going to have to wrap up.
Yeah.
Thanks.
I'm almost at my conclusion. Punitive measures were implemented at the base, but not at the top. And so that became one of the largest inequities that we discovered in the institution, was the application of its policies. And so I think the big lesson in all of this for the institution was that, yes, there is a huge problem in there with respect to embracing the principles of EDI and practicing them, but that they have a responsibility. If they're going to improve the outcomes for the people they care for, they have to implement the recommendations that were generated by this report. And I recommend that you take a look at those 10 recommendations. They were originally 20, but I took a chapter from Moses and I brought it down to 10. So should be easy to remember. Thank you.
Thank you very much. Okay, finally, we have Dr. Timothy Evans. He is the inaugural director and associate dean of the School of Population and Global Health in the Faculty of Medicine and associate vice principal, Global Policy and Innovation. Tim has served as the Senior Director of the Health, Nutrition, and Population Global Practice at the World Bank Group, Assistant Director General at the World Health Organization, the Director of the Health Equity Theme at the Rockefeller Foundation, among many other high-level positions. He has been a co-founder of many partnerships, including the Global Alliance on Vaccines and Immunization, as well as efforts to increase access to HIV treatment for mothers and innovative approaches to training community-based midwives in Bangladesh. Thank you very much for being here, Tim.
Thanks. And as Seema just indicated, the punitive measures, I'm an indication of that. You've got to listen to me for a few minutes before we get into back and forth. Apologies in advance. I just wanted to try and take on this critical issue of a system shortfall in creating a system that is inclusive of the diverse needs in a population. I think my contribution to this panel, if I can call it a contribution, would be to take a broader systems perspective, because I think this cuts through behaviors, whether intended or not only in our current context, but virtually across all complex health systems, and requires a bit of a systems approach. I'm going to focus on something that I think universities are very well positioned not to make a diagnosis on simply, but actually act on, and it relates to the workforce. So we've woken up post-COVID. We've gone from the pandemic frying pan into a whole set of polycrises. But in the context of the workforce, we have an acute crisis in Canada, with 20 to 30% of Canadians not having regular contact with healthcare services of different types. And some sense that, as my panelists have made abundantly clear, that may be the aggregate lack, but in various communities that lack of contact and continuity is much worse, especially in communities of greater need. And we find this in many, many places in the world. The European region of the World Health Organization issued a crisis statement on the state of the health workforce in Europe, and indicating that all sorts of challenges related to obtaining the objectives of inclusive universal systems were at risk because of a relative lack of attention to the system dimension of the workforce. In making that diagnosis, I think it's really important from a systems perspective to realize that our health systems are increasingly interdependent, right? It isn't the government Quebec that runs and manages the workforce on its own, nor is it a hospital in Montreal, nor is it certainly the government of Canada. But if you look, for example, at global demographic change, all OECD rich countries are moving to situations where they have decreased fertility and aging populations, and they don't have a productive age workforce that meets demands and needs for all services, inclusive of health. Now that diagnosis is relatively robust across multiple countries, and it manifests itself in the health sector. Yet, we don't really seem to understand that not only from a demographic perspective where we have decreasing numbers of productive age individuals entering the workforce, that we're also got two other dimensions that are very, very functional in health. One is that needs are increasing because of changes in the age structure of the population. Elderly people almost invariably have more than one diagnosis and need much more time. And if you look at the trends and data on taking care of people, you find that practitioners are actually spending more time with patients, in part because we've got greater complexity that needs to be managed. But in addition, you've got demands. People understand what's aware, and so these needs and demands are far outpacing the generation or the supply of health professionals in the workforce. So this is a systems disequilibrium. I'm an economist, and these are the market failures that we have and that we have to wake up and try and deal with. How is Canada dealing with this across our 13+ jurisdictions? I think Larry Rosenberg said something about this morning. In the absence of our ability to find sufficient health workers in our various jurisdictions, we're going to the international markets. We pay rich contracts to recruitment agencies who show up in Dubai and other workforce forums and say, hey, Prince Edward Island has a contract for 300 nurses. Can we take all the graduates from the nursing school in Malawi and have them come, and we'll accelerate immigration and have them work here next year? Great for PEI. How good is that for Malawi? And who subsidized the education of those Malawi nurses? Talking about unfair subsidies to education in Quebec, just for example, right? Okay? This is a gross violation of WHO's ethical code of conduct for recruitment of health workers globally. Canada signed on to that ethical recruitment, and we're in flagrant disregard of it. Does that matter to anyone? It does to me, because my area is global health, and it pains me to see that we're part of the problem in terms of other countries achieving their health workforce objectives. So, what are we going to do about it? My view is that we have to start right here in the academy, because we are the ones who have responsibility for training the workforce in very large proportions. And I had the opportunity and privilege of being part of a commission, a Lancet Commission in 2010, which was focused on health professionals for the 21st century. It was the 100th anniversary of the Abraham Flexner Report, and it was trying to issue a new vision with respect to how could we train health professionals to ensure that we had the right numbers, the right competencies, the right look and feel of the workforce to respond to the challenges of the 21st century. We made recommendations along two lines. One was instructional reforms. How would we teach differently? What would be the content of curricula? And secondly, how would we change the institutional structure of education more fundamentally? I'll talk briefly about these. Instructional reforms. The Commission identified 3 types of learning that are fundamental in education, and in its analysis of health professional education around the world, it showed that virtually all institutions do a good job with respect to one of the types of training, informative. We're very good at teaching technical skills so that people become experts in specific areas. But there are 2 other types of learning where you saw progressive superficiality in the content of training of health professionals. The first was around normative learning. And I think, as we've heard today, there are huge issues related to how we think about rights, equity, and go beyond sort of the simple jargonistic way of flipping those terms around and saying, yes, we respect rights, and yes, we believe in equity, but actually walking the talk. What does it mean in discrete communities? Secondly, we have, in the context of the normative front, there are huge issues with respect to different conceptions of health. And in the new undergraduate program in population and global health that we just started this year at the university, this global health undergraduate program started with 4 weeks of indigenous health. And because we felt that was so important to have indigenous health perspectives inform young Canadians' view of what constitutes global health and avoid a sense that there's some hegemonic view that we can impose from what WHO on a singular conception of health. Lastly, and I know that there'll be a panel on this, and just to further emphasize the need for more normative training, but we're in a digital revolution where algorithms are increasingly controlling our lives. There are massive issues related to the extent to which those algorithms are biased and actually not going to generate reliable information with respect to constituencies that might think they're beneficiaries. And to do that, not only in terms of understanding the bias, but understanding how we regulate those sorts of new technologies requires a massive group of individuals and experts who have competencies in ethical, regulatory recommendations, and we're not producing those individuals in institutions at the moment. So those are the normative competencies. But the biggest lacume is in the third area of learning, which relates to transformative learning. And transformative learning is about recognizing that anybody is trained as somebody who needs to be an agent of change, a leader. And when you look at the number of competencies that are trained, that are in training, health professional training programs that focus on leadership and managing and taking change and thinking out of the box and being creative and challenging the system's goal and doing that with a strong ethical rudder, we have a massive shortfall. We're not addressing that nearly the extent we can. And as part of our efforts at the School of Population Global Health, we're thinking about working with Desautels to generate a program on global health entrepreneurship. So we have a big agenda on instruction. However, that overlooks the other area of recommendations on institutional change. And here, there's a massive agenda. Because if we don't have institutions that are responding to the needs because they're hamstrung for various reasons, then it isn't through instruction that we're going to make the change. So if we had to double the number of institutions in the country to meet needs for training the health professional workforce of the future, it isn't by changing the curricula that we're going to do it. We have to invest and create new institutions. Toronto has 2 new medical schools, York University and TMU, right? That's perhaps part of the systems change. Vancouver, Simon Fraser University has got a new medical school. But maybe we need to think much more systematically about how that supply side of institutions needs to change across the entire spectrum of health professionals. But let me just focus on 2 areas of institutional reform that I think relate particularly to equity. The first is on admissions. To what extent do the classes that we are admitting into our health professional training programs reflect the populations that they are meant to serve? And I don't think we're doing a sufficient job of understanding and matching that. Because we hold ourselves to the standard that there is merit in what we do. Your GPA is a reflection, an exclusive reflection of your merit to be a health professional. And if you look, for example, as others have, at how well GPA corresponds with socioeconomic status, you'll find it's one of the tightest correlations possible. People who are born with golden spoons are much more likely to get excessive tuition and practice tests. And in the United States, they have ghostwriters who write their exams, or people that correct their scores such that they will get into those institutions. And Michael Sandel has written about this very eloquently in The Tyranny of Merit. And although his focus is in the context of the US system, we shouldn't kid ourselves that those same challenges of merit based on a very artificial criteria are sufficient for our system. So I think we really have to fundamentally rethink admissions policies. The other is with respect to accreditation. And here I want to look at the challenge of the reality that we have many internationally trained health professionals in Canada who are currently massively underemployed. And the inertial forces that are before those individuals in trying to find a way in which they can exercise the competencies that they've trained, or even do retraining or upgrading to get into the workforce quickly, are overwhelming. And many of you might have seen the case of the occupational therapist or the physiotherapist from the UK who's throwing up his arms and saying, it's 2 years before I can even think about practicing, right, in the context of the UK. So that is also got a very strong ethical issue on two fronts. First, the bar being set much higher for those trained internationally is an effort to protect markets. And we need to admit that, right? And it's actually has a very negative effect in terms of addressing demands and needs in our system. So while it may be good on protecting markets and ability to bill for certain types of health professionals, the costs from a systems perspective are mortal. The second part of it that I think is really important is that many of those internationally trained health professionals are people of color. And that is something that in this day and age, if you look at the way in which we continually discriminate based on issues of where you're from, what you look like, and the way you speak or what you speak, I think totally unacceptable. So with that, I'm going to stop, but just to say that I think from something that educational institutions have an incredibly important role to exercise leadership in, I think we need to be much, much, much more proactive, and I include myself in this as part of the problem, on really pushing instructional and institutional reforms that are going to address the overall performance of our health system so that it is and can walk the talk on equity and inclusion. Thank you very much.
Thank you very much for including me on this panel on inclusion and equity in healthcare. I'm so sorry I'm not able to be with you now in Montreal. However, the events of the weeks and days have wrought great violence on our campuses in New York City, and tremendous sorrow and fear among our students and faculty. So we are all here trying to bring some, not just comfort, but companionship to those who are suffering now. What I wanted to bring to the panel is very specifically about how healthcare inequities have come finally to the surface of the medical professions and the medical education's notice. It's not like they weren't there before COVID and Black Lives Matter, but they are now radically exposed, not only to those of us inside healthcare, but most importantly to patients who look to healthcare for their own safety and care. Since the events of COVID and Black Lives Matter, the medical establishment, at least in the US, has really girded itself to look squarely and unflinchingly at healthcare disparities, at the difference in maternal mortality between white and Black women, at the ways in which students from minoritized communities either have a hard time getting into medical training or have a hard time doing well in medical training. So how can the healthcare industry help us? They can help us a lot to confront these issues. And again, it spans from how we treat our students, how we treat our faculty, to mostly how we treat patients from all classes, races, genders, sexual identity groups, to get fair and decent health care. Now, what has this meant for us within the medical schools and the hospitals? It has meant far more engagement with the patient communities that we serve. Many of our big academic medical centers are placed within communities of color, communities of urban distress. That's where they happen to be. And the medical centers are at times not as responsive to the kinds of healthcare problems that poor patients, patients with low resources, uninsured patients are able to get for the particular illnesses that may come more to them than to persons who are not under-resourced. So how do we effectively and fairly treat patients with, say, childhood asthma, which is much more common in the housing projects in New York City than in suburban dwellings? Or how do we respond to food insecurity and the ways in which many of our patients are simply not able to get the kinds of food that they need? I could go on with the kinds of health concerns. It is the case that patients who do not have, and remember, this is the US, so we do not have a single payer plan. We do not have a universal healthcare plan. And that's probably where industry can help us the most in turning that around. But how can we guarantee that persons who get, we call it Medicaid, which is the not very generous health insurance for persons who are working at low pay jobs or not working at all, persons who don't make enough income to be able to buy the private health insurance. So how do we make it happen that a person on Medicaid or a person without insurance is able to get subspecialty care at our brilliant clinics without waiting for months and months? How can we puncture through the two-class care that has come up, and I'm sure you see this in Canada too, where persons of means are more able to receive care when they want it and from whom they want it than are persons undermeaned. So, and then I also want to say something about the education space, because it is not only that patients and persons who come to us for care are not getting equal treatment. It's also the case that the students who aspire to become physicians, nurses, social workers, therapists, that the aspiring students from minoritized communities, again, race, gender, ability, we realize that we practice ableism within our schools, and we make it difficult for a student who has a disability of any kind to either get admitted or do well. So how do we equalize the opportunity and the education for persons across the race, class, gender lines? It's very hard. There are inbuilt biases in even things as simple as grading on examinations or on clinical rotations. The persons grading them tend to be white and male and middle to upper class, and may not be able to astutely judge a student's abilities and a student's competence and a student's even activities or behaviors if they're being held to a standard that simply doesn't apply to them. So we are doing a great deal within the medical centers, not just describing, but inventing methods of grading and of assessment of students that is not as tainted by implicit bias, unconscious bias, as the current situations are. So those are a few of the ways in which inclusion and equity are at risk within healthcare and within health education. And I hope you can see, as I'm enumerating them, how vital a part that the health industries could play. I mean, we need to be dealing directly with the health insurance industry. We need to be dealing directly with the pharmaceutical industry. We need even to be dealing directly with the industries of our own health delivery systems, which is to say our own CEOs, our own C-suites, whether our institution is a for-profit institution, a not-for-profit institution, a city or county hospital institution. All of these are going to have tremendous benefit if the faculty, the students, the persons who populate the medical centers, if we were to have more direct access to speak, to discuss, to think aloud, to negotiate with the industries whose pressures constitute our workday lives and constitute or limit the care we're able to give to our minoritized and under-resourced patients. I hope some of this makes sense on a Zoom from afar. I laud what you're doing. Lindsay Holmgren, you're one of my heroes. As a person with French Canadian heritage, I sure wish I were with you now. Thank you.
Thank you very much, everyone. Okay, so I know I have many questions, but I'm going to defer to all of you. My mind, to quote Heather from earlier, my synapses are firing. We're going to have two people with microphones. I'm about to hand this one over to one of them so that we'll have people on either side of the room to hand you a microphone when you want to pose a question. Please do wait till you have a microphone so that it can be picked up on the recording. Thank you very much. Okay, well, this one's working. Do you want to take? Okay, so this will be the microphone.
I'll be in stereo. Okay. Thank you so much. Honestly, this is such a rich discussion, and listening to each one of you progressively I think for me, it's just sparked a number of questions, but I'll try and limit myself. Certainly when I think about all of your reflections, I keep looking up at this title, and when I think of, ethical management, I think it's so inextricably linked to empathy. Meaning, I don't know if you all know that fable of blind men and the elephant, but, we all stand at a different spot around this animal of healthcare. And I'm just wondering what your thoughts are on how much or how little progress have we made within the system to advance representation. So, when I think about you, Sita, stating, we really need to get out there where people, play, pray, live, work, and we think about the admissions systems, but also even in training our next generations. Perhaps, some of that training should take place out in the field by going into those communities to be, entrenched in what's going on. So I guess part of my question would be, should we be thinking a little more expansively, or perhaps you're seeing modicums of improvement here, but a little bit more about thinking empathetically in our training, within the system educationally, at the medical level, and what can we do in order to try and expand the breadth of what constitutes, for example, healthcare or total care, holistic care.
I'm happy to start with a few reflections. So our incoming medical school class has made significant progress when we think about racial, ethnic, gender diversity, including people with disabilities. I think, and this relates to some of the comments from Dr. Evans, a challenge when it comes to how does that impact the service ultimately delivered is in the mismatch between the incoming classes and the current faculty, and then the mix between what an academic institution is responsible for in classroom learning environments and what they see role modeled in clinical learning environments, in terms of the difference between how we say we do things and then what we actually do. I think people have different working definitions of what they see as empathy. I tend to mostly discuss rights-based principles, where I think there is not as much openness for lack of clarity or lack of shared understanding. I think the link to empathy has to do with confronting the idea that we don't actually recognize each other as fully human in this state, right? Because people are not going to agree to the full realization of my human rights unless they can first see me as fully human and then treat me as such. And the other point that I would link this to is the idea of selective accountability that Sita referred to, because we select away from accountability, including in attending physicians or clinical leaders who are role modeling inequitable healthcare treatment. And one thing I would say about the state of the health workforce is we can neither train nor recruit providers at the rate of attrition from the health workforce. It's our current reality. We have to change the rate of attrition, and we cannot fundamentally do that unless we are addressing the fact that over 80% of Black, Indigenous, and racially marginalized workers experience racism on a regular, if not daily basis in our healthcare system. I think this speaks to some of the systems you, Dr. Evans, was mentioning as well. And so, I'm at the place in my career, 16 years in, I'm also an executive coach, in addition to being a physician and a vice dean, where I think if we don't focus on supportive accountability, including at the very top, we are going to be in a cycle where we recruit more diverse learners who experience increasing levels of harm in the hamster wheel that we're currently on.
I would add, particular Inuit kind of context, and I'm going to talk very micro in a way. At McGill, within medical education, before I arrived 4 years ago, there was no module, there was no pedagogy specific to Inuit. So, there is certainly Indigenous pedagogy, but with really very little mention in relation to Inuit. So I now teach modules to med students, and I teach an academic course to MSc and PhD students in family medicine, and then I lecture in a lot of other places as well. The point of some of that for me is really to humanize people instead of pathologizing them, because some of the nature of some of that pedagogy has certainly been to describe disease, syndromes, diagnosis that has a particular application to Inuit, and of course that just turns us into disease carriers, really, as opposed to human beings. So to go to your point about empathy, I think it's a pretty important part of that kind of pedagogy to talk about human beings. And I talk a fair bit about history because some of my background is in history, and we didn't just arrive out of thin air, you know, like we've been here for a very long time. That's not happening to nearly the same, that kind of teaching, from what I understand, is not happening to nearly the extent that it should be across Canada, across medical schools across Canada. Because as far as I know, the academic course that I teach at McGill is the only one of its kind in Canada. So, which I find very surprising, and I keep wanting someone to tell me that I'm wrong about that, but nobody has. So we need to do a lot more in terms of that kind of humanizing people that medical professionals encounter in their practice.
Yeah. And if I can add, I think as healthcare professionals, you kind of know. So I teach this in my unconscious bias trainings, but you kind of know that you're empathetic. Some people aren't even sure. But if you get that little taste of vicarious trauma when you're dealing with your patients, right, that's an indicator that you are empathetic, because you won't feel that unless you truly had empathy. And then there's the cautionary tale, because if that vicarious trauma becomes too intense, as it did in the COVID pandemic when our healthcare workforces were overwhelmed, then you are putting the risk to the healthcare worker of compassion fatigue. And we know that that also happened. It happened in ways that people left the profession of healthcare because they were empathetically burnt out. And I think another thing to do is be cautious. We're talking about research, we're talking about ethics. When you are doing even your research and when you're looking at people and reporting on what you're finding about them, your empathy has to be there, and your sociocultural sensitivity has to be there. And again, I'll give you another example based on COVID. The famous pulse oximeter, everybody probably knows what that is, that takes the level of, measures the oxygen level in your blood. The pulse oximeter, studies going back to 2006, 2007 had shown that this device actually gives inaccurate information when used on dark skin. It actually gives reads that the O2 level is higher than it really is. Early on in the pandemic, specifically in the US, many Black patients were discharged prematurely. They were admitted for COVID and discharged prematurely, sent home, where they either got worse or they died, but they succumbed to the disease. Because pulse oximeters were being used and were indicating that they were O2 fine, but they actually were below, much below. And if you look at some of the research headlines that came out around the pulse oximeter, you see headlines like this. Pulse oximeter's accuracy interfered with by dark skin, or dark skin interferes with the accuracy of pulse oximeters. No, you see this. These are the ways that the things are worded. Where what you should be seeing is that pulse oximeters are or can be inaccurate when used on dark skin. So even in the way we present what we find, we can often be socioculturally harmful because we are putting blame and shame on the patients. One of our most prestigious Canadian healthcare institutions reported that in terms of Canadians, 48%, so almost 50% of publicly funded medications are due to Canadians 65 years and over. So it's an ageist statement. You're saying that 65 years and over, these people are sucking up 50% of publicly funded medications, but 50% is also used by all the other younger and slightly older age demographics. And then you don't ask the actual question, well, why is that happening? Why is it that these people over 65 consume so much of our publicly covered medication? What can we do? Why? Maybe you will look at it and see, oh yeah, they don't get coverage from private health insurance, right? Because they're considered too old. And so we see ageism is affecting our systems, but then the powers that be do nothing about it. So there's a social accountability we have to have in our practices at the clinical, at the teaching, at the research level, and the empathy that goes with it.
So, just very quickly, if I can. Is
Yeah.
that
Yeah,
it's
wait,
just,
time.
I think I just add a great set of comments here, but I talk about structural empathy and barriers to structural empathy. I was part of a COVID immunity task force during the pandemic, and we were trying to get research to places that it was needed in order to understand the pattern of infection and vaccine-acquired immunity in the population. And what it appeared very quickly is that there wasn't equal opportunity, there wasn't really democracy in the way that COVID affected individuals. There was predilection on all sorts of other disadvantages that individuals met. And so we said, well, we've got to get research into some of these areas where it's not happening, like long-term care settings or essential work settings, meat packers in plants, or people in incarcerated settings, right? Well, what was really interesting is that, first of all, we couldn't get a flow of research proposals because there were no researchers working in those areas. So, in fact, where were all the researchers? All the researchers are in tertiary care institutions focused along the corridors of health power in Canada. Right? You've got the MUHC and the CHUM here on, analogs to one another in Montreal, and then you've got the University Avenue in Toronto, where you've got, about a massive concentration of the research capacity, and those people do not have access to the places where the problems were most, and no knowledge. So then we got proposals in from community-based groups who are doing and interested in illuminating the situation of infection risk in North Montreal or in Brampton. And the way in which those proposals were peer-reviewed showed arrogance and absolutely no empathy. Oh my goodness, these people have no publication record. Right? Their designs are just not adequate. Right? The sample size calculation doesn't show that they have a full understanding of, binomial distributions and things like that. No sensitivity, right? And we were part of this, but it was glaring, right? That we had a structural lack of empathy for the recognition that we needed research in communities that were at greatest risk. And we had a structural deficit because everybody working in those institutions that are hyper-concentrated, they're massively empathetic. It's just that they can't express that in the places where it's needed most. So we have to address, again, some of these structural issues in our systems if empathy is really going to go beyond the individual encounter with individuals and has a much more system-wide manifestation.
Thank you very much. So we do have time for maybe one more question. Oh, okay, great. Thank you.
Yeah, thank you so much for the presentation. So my question is directly to Dr. Evans, but I mean, any other panelists can chip in. Since we're approaching the problem of shortage of medical staffs or medical personnel within Canada from a systemic approach, I was wondering, from your experience, are there better ethical ways of bringing in, or recruiting foreign trained personnel from outside of Canada? Because also from the approach of migration studies, these immigrants too, they do sometimes do remittances to their home countries. They sometimes transfer knowledge, right, that they've gained also from Canada, which is also a benefit on its own. So I was just wondering, yes, we do understand that it can be ethically questionable given, you're removing people from somewhere else, but from your own suggestion or approach, would there be other ways of doing that in a more ethical way?
It's a great question, and I think it's really important to recognize that Our ethical imperative is how do we manage health systems interdependence ethically, fairly, right? And our blind spot is we don't think of the ramifications of that interdependence, right? We saw that in vaccine nationalism in the context of the pandemic, right? We said, okay, well, if we all get our vaccines in Canada, and we're lucky, thanks to smart bureaucrats who bet and got us 180 million vaccines for a population of 40 million. But we didn't have that same intelligence and that fairness principle thinking about, well, how can we make sure that we've got a production and distribution capacity for 8 billion, right? So that interdependence is inevitable. It's a function of how we measure, how we manage it fairly. And I think that's not a simple issue. But in the context of the health workforce, first, we have to recognize everybody's right to move to a place of work. So it isn't an issue of saying, you know, we're going to close borders and make it illegal for anybody who's a health worker to leave their country or something like that. That's absolutely... Shouldn't we be thinking about how we can strengthen their health professional training systems and perhaps linking with them? Now, I'm going to say something very perhaps challenging for McGill, but we could say that as part of our responsibility to have ethical generation and recruitment, we think we need to work to double, triple workforce generation capacity in the countries that are sending us, where we're sending us health workers. And we're going to do that by, you know, partnering, sharing in the development of faculty and having long-term engagements so that those countries are going to have some support from Canada, and we'll get our foreign affairs to invest in that. But here's a challenging issue for McGill, because McGill doesn't like to partner with universities that aren't at its standard. There's a very real issue here that we think we need to partner with those that are at the top. And I think that's a problem. So we have our own ethical issues internally that we need to say, actually, partnering with new institutions, say in Ghana, University of Health and Allied Sciences, been on the market, it's been around for 10 years. Actually, that might be a much more beneficial partnership than partnering with Oxford University. Right? So I think those are the sorts of things that institutionally we need to give clear incentives that we're going to be part of a solution, and we have to actually move it. We can't wait for bureaucrats in Ottawa or Quebec to say, universities, you should do this. I think we'll be waiting a long time before we get any signal on that front. But if the leadership of this institution is mobilized to say, actually, we're going to be part of making the difference, then I think we can begin to, you know, pave some of the opportunities for walking the talk on ethical recruitment practices.
Okay, well, I think that's a great challenge to ask McGill to rise to. And with that in mind, we will close this excellent panel for now, and we have about 10 minutes until our final panel of the day. Thank you very much, everyone, for your outstanding contributions.